And thanks to everyone for putting their name and information in the chat. So welcome to our webinar today, where we're discussing health and housing partnerships and housing options, and more specifically, housing options for individuals with substance use disorder or substance use related challenges. My name is Jamie Blackburn. I am the presenter for today, coming to you from Corporation for Supportive Housing. CSH is a national housing advocacy organization, community development finance institution, and national technical assistance provider. Through HRSA, we do work with cities and states and organizations across the country, providing technical assistance and training and all things relating to housing and homelessness, but more specifically supportive housing and those populations served within supportive housing. I would come with a pretty strong background in working in direct service with individuals with substance use disorder, having led the largest harm reduction syringe exchange program in Massachusetts for several years prior to coming to CSH, as well as serving as a director of a methadone treatment program as well. And so I'm looking forward to a very robust discussion today. Don't be shy. If at any time you have a question, please feel free to come off of mute and say your question, or I'll shout it out from the chat if you're more comfortable that way. So great. I am coming to you from just north of Boston, but if folks feel inclined, please feel free to show us on the map where you're coming from. Use your good opportunity to practice using those Zoom annotation tools, which will be on your toolbar down at the bottom, where you either at the bottom or at the top, depending on how your screen is configured. Try to find those annotation tools, show us on the map where you're coming from. If you can't figure it out, totally fine. I see folks are dropping it in the chat as well. Great to see a couple folks have figured out the tools. Excellent. Folks from Georgia, Indiana, Wisconsin, Texas. Great. Wonderful. Wonderful. Thanks, everyone. Moving along. So our agenda for today is to cover, understanding, getting a basic understanding around substance use, the context in the current climate, given the constraints of the pandemic and just all of the new data that we have coming out, that we're going to be sort of sharing a bit of that with you, of what we're learning around substance use in the current context, covering the importance of harm reduction, which for some of you, depending on your role, you may have covered or received training on before, but it's very important for level setting in any conversation when talking about substance use to cover what harm reduction is and get that refresher, as well as housing first. And then we're going to jump into what are some of the housing options and models that are best suited and designed for folks with substance use disorder, and how you might be able to access those resources in your particular location. So before I get started, if there's any questions, please feel free to drop them in the chat, and I'll stop at any time. Great. So why is this topic to talk about substance use and substance use housing options? Why is this so timely right now? And why is this so important? And, I use this example of headlines from around the country to show that, the pandemic has had, of course, in its own right, a dramatic effect on people's health and well-being around the country, but it's had a dramatic effect also on exacerbating the ongoing substance use and mental health crises that have been gripping the country, and then exposing that really dire need for housing across the board. And it's really doubled and trebled the challenges that folks had prior to the pandemic that were struggling with substance use disorder or homelessness, and has really just taken it to the next level and exacerbated it. So this is a really timely topic, given the times that we are all living in. And so to capture some of this, the Centers for the CDC and the Census Bureau paired up to do a new survey they called the Household Pulse Survey, where they're trying to capture on a number of metrics around the country some more up-to-date, more time-sensitive data, snapshots. And one of the metrics that they look at is they use a screening for depression and anxiety symptoms and to track sort of the status of Americans' mental health. And between April 23rd and May 5th, almost 35% of Americans reported symptoms of anxiety and depression. And so this really shows that the impact of the pandemic is very much still being felt and exacerbating this. And then some other data that I wanted to highlight are specifically regarding substance use. And this graph on the left shows sort of aggregate monthly overdose rates. Starting in February 2016 all the way until August 2020. And this intersecting line right here shows you where the pandemic started and the response started in February 2020 right here. And then you see this dramatic incline on these graphs across for overdose deaths, opioid deaths, and then specifically for synthetic opioids. And that's when we talk about fentanyl and other types of substances. And then the map on the right shows you the percent increase in overdose deaths between January and August of 2020 as compared to January to August of 2019. And you can see in the darker shaded, it's over 60% increase in overdose deaths. And so you can see that certain states in particular stick out. So, zoom in and take a look on wherever you may be located. But you can see how this has really had a dramatic impact on folks that are struggling with substance use disorder and the impact of the pandemic. So this is a timely topic and understanding what are the resources and how you can support some of these needs for folks that might have these challenges. And it's a good thing to remind everyone that we are still operating within general scarcity around affordable housing, not just for folks with substance use disorder or people experiencing homelessness, but 1 in 4 low income at risk individuals, only 1 in 4 are able to access the rental assistance that they need to maintain housing stability. And we know that people with substance use disorder have additional barriers, additional challenges to accessing resources and housing. And so how do we square this? How do we address this need? Partnerships and persistence are really critical ingredients to addressing this scarcity. And of course, there's no one magic bullet approach, and certainly where you're located, which state you're located in, really makes a huge difference on what resources are available. But those 2 ingredients are going to assist you no matter where you are. Great. So I think it's very important whenever I lead a training discussing substance use disorder. It's really important to have a shared understanding of language and its role in perpetuating stigma, which is an ongoing issue whenever we're talking about substance use. And so, checking our own use of language, making sure that we're using language that is not stigmatizing or promoting stigma. So addiction versus substance use disorder, addict versus substance user or user, substance use versus substance abuse. Our language matters. And there's been a lot of research done on how language choice, particularly in healthcare, can really make a huge difference in whether someone chooses to engage with their health, engage with or pursue their goals, or have access to quality care. This matters. So it's important to check our own language and choices of language at the door whenever we're having these conversations. And so, stigma is alive and well. And this is really, really important and as I mentioned, that it impedes quality of care, utilization of services, despite ongoing efforts by advocates and others to address stigma, it's remained stable. And I've put citations to some studies that dive into this deeper at the bottom of this if you're interested in looking into this a little bit more. But essentially, we know that a large percentage of Americans are using substances of some kind. And therefore, it's really important that we address our stigma around this issue because it's pervasive and we need to talk about it. So when we're addressing substance use, of course, it's a huge tent. There's, and the challenges and needs that a person might face greatly depends upon the type of substance that they're using and then the needs that arise from that. So opioids, of course, bring a lot of the media coverage. They bring they bring a lot of the greatest risk along with them. We're talking heroin, fentanyl, or other prescription opioids. Overdose prevention and response obviously is the number one concern when we're discussing this. That's the driving factor on overdose rates is the amount of fentanyl that is available in the general drug supply. It also brings up issues of disease transmission and prevention, HIV and Hep C in particular. Alcohol, second in line here, brings risky behaviors, long-term health consequences, and liver functioning, of course. And then, of course, there's dangerous withdrawal if you have a long-term dependency on alcohol. And then finally, stimulants such as cocaine and methamphetamine also brings issues of infectious disease transmission. And it's also important to note that there's another challenge around managing this is that there's no medication-assisted treatment options at this time for these particular substances. And so treatment choices are often psychosocial, behavioral therapy based. So there's no medication assisted treatment options, unlike opioids, where we have several different options to choose from when connecting people to resources. So any conversation about working with individuals with substance use disorder, and especially in particular when we're talking about connecting them to housing resources, you need to have a conversation about harm reduction. What is harm reduction? Why is it important? I'm sure that some of you, and please drop it in the chat if you have taken trainings on harm reduction or you're familiar with it, or if you have not, sound off, let us know. But it's evidence-based. It's an evidence-based approach and philosophy, really, to working with individuals with substance use disorder. It has demonstrated effective outcomes. It's rooted in dignity and rights of all people that are actively use substances and their right to remain safe and make their own choices. And ultimately, safety is the name of the game when it comes to harm reduction. The Harm Reduction Coalition has this wonderful definition, but really, when we're summarizing it, it comes down to safety and focusing in on strategies to mitigate negative outcomes of a behavior rather than the behavior itself. Folks we all engage in behaviors every day that carry some inherent risk, and that we're not likely to just simply stop engaging in those behaviors on a dime because someone tells us to. But what strategies can we do? What approaches can we take to mitigate any risks that come along with that and keep people as safe as possible while they make their own choices? And that's what harm reduction is all about. We all use harm reduction in our everyday life. If you wear a seatbelt, if you wear a helmet or wear a life jacket, if you ever used a vape or a nicotine patch or nicotine products to help you stop smoking, if you've ever received sex education or used condoms, these are all examples of harm reduction that we use in everyday life. And so people often think that harm reduction is just syringe or needle exchange, but it's actually broadly applicable. I like to always use the example of, particularly for healthcare, is diabetes management. Harm reduction is an approach that is very effective in working with folks that require diabetes management. And so it's evidence-based, it's effective, and it will ultimately yield better outcomes for everyone when taking this approach when working with substance use disorders. And so before I dive into our specifics around housing options, I just wanted to shout out a comment in the chat from Marcella McGuire, who's our Director of Health Systems Integration here at CSH. She she says your local housing authorities could be getting new vouchers for persons experiencing homelessness. And then she has a link to the HUD notice in the chat. So new resources that might be coming to particular neighborhoods and cities around the country. So take a look at that so that you can get some more information about your local resources that might be coming to your local area. 70,000 new housing vouchers are coming online. Thank you, Marcella. So this is, again, it's really timely. New resources are coming. So knowing what the resources are in your community and how to connect with them is super important. I'd love to know for folks if they have received training in harm reduction before and working with substance use, people with substance use disorder. Sound off in the chat if you have, and then I see some folks have. Okay, great. Thank you, Erin. Great. You know, and I assume that most folks that are participating have had at least some exposure to it, but it's always important to level set to make sure that folks are all getting this information, because it's such a critical core competency when working with folks with substance use disorder, or even if you're not involved in direct service, if you're facilitating referrals. This is just a really it's a good concept to have in your wheelhouse as that core basis. So thank you. Great. So we're going to cover supportive housing first, and then we'll dive into recovery housing and what those options look like when working with folks with substance use disorder. Primarily, these are your two options that are going to yield the best outcomes for folks. And so starting with supportive housing is an evidence-based approach. It's designed to meet folks that have complex barriers to housing, that might have needs. It's essentially affordable, deeply affordable or subsidized housing combined with wraparound supports for folks. And we're going to dive into more of the specifics as we go forward. It's rooted in a housing first and a harm reduction framework, and we're going to cover housing first in a minute. But most importantly, it recognizes, and this really comes from that housing first framework, that housing is the platform from which all other successes or goals can be pursued and ultimately achieved. And that without having those. Oh, we had a request for a copy of the slides. Yes, we will be sending, these will be sent out afterwards along with the recording. So thank you for the question. And so, it recognizes that it's very difficult to focus in on maybe some of your other goals, whether that is treatment and recovery and sobriety, or maybe it's a health specific goal, or relating to a particular condition, or any other goals that you might have, employment or other skills. It's very difficult to begin to think or address those when you lack stable housing or a safe environment in which to live. So recognizing that housing is the first ingredient to this journey to achieving other success and goals is the underpinning of this framework. And I'm assuming folks have also had some training in housing first, but if you have not, please let us know. And so I love this graphic because it really shows you why housing first makes such a logical sense, and as compared to what we would call a housing readiness model, where folks have to surmount certain barriers or scale certain objectives before they can be deemed ready for housing. And so whether that's they have to enter shelter first, they have to achieve sobriety, they have to be within recovery for X amount of time, they have to enter transitional housing first, and then they get to permanent housing. It all creates opportunities for folks to, and on here they're labeled as fail points, but really it's because the system has failed them, not because the person themselves have failed in these objectives, but that these are roadblocks that are put in their way. Whereas housing first is based on the idea that You connect someone to permanent housing first, and it provides them that platform upon which they can achieve those medical, behavioral, mental health, income, and any other goals that they might have. And that ultimately leads to them having better overall stability and allows them to thrive in their communities. And of course, there's enormous amounts of evidence that backs up why housing first is such an effective approach. It's certainly not without its challenges, and I'd love to hear from folks if what some of those challenges might be. It's certainly not all easy. When operating within a housing first framework, and there are strategies to address some of these challenges. And something that we talk about a lot with the permanent supportive housing providers that I work with in Massachusetts and other New England states. And it's a common topic that it's not always easy, but it's certainly an approach that is very effective. And this rigorous evidence base really can demonstrate that over time we see less use of costly services, fewer emergency department visits, fewer hospitalizations. People are housed for longer, and their follow-up rates and success in housing, they're more likely to be housed at 18 to 24 months. So we've got significant amount of research that shows the effectiveness of this approach and keeping people housed and seeing them thrive in this housing. And then for supportive housing specifically, we see the same types of outcomes when you connect people to supportive housing and those wraparound services that they need. And it's really the services that are key here, that people are able to maintain their housing for at least a year, and that use of detox services, ER services, hospitalizations, all of these markers go down over time. And so when we're doing trainings on supportive housing, and we certainly could spend an entire training on diving deep into what quality supportive housing means, and we certainly do those trainings a lot, and we're not going to dive that deeply today. But one of our favorite ways to describe supportive housing is this sort of four-legged stool, right? You have the housing, of course, you have the property and housing management, which is a really critical piece and ingredient to making sure that this is successful. You have the supportive services, those wraparound services that are voluntary. And then finally, the project's relationship to the community. And of course, this is referring specifically to a single site permanent supportive housing project. But we often describe it as the sort of the four-legged stool and what it takes to operate successful supportive housing. So again, I'd love to hear from some folks if they have existing partnerships with supportive housing providers, or if they are a supportive housing provider in their community. Have you, or maybe this is your first time ever hearing or learning about what supportive housing is. We'd like to hear that too. And I do see a couple folks in the chat previously that said that they were, had worked within housing programs. So we might have a couple folks on the line that are familiar with supportive housing, already in their community. But if you're not, I'm again happy to answer any other questions that folks might have. But it's important to know, we ask this question because it's important to know who in your community, where potential partnerships might be, where you might be able to make referrals to if that is your intent, and really just doing that assessment, that landscape scan in your area. Who are the supportive housing providers, and who should maybe some potential partners be that you could be getting to know and strengthening those connections with. Great. So if there are no questions about what supportive housing is, we'll jump into recovery housing. And, I often get questions when doing trainings and working with particular states or communities about, or people thinking that recovery housing is the same as supportive housing, or supportive housing, that if it's supportive housing directed for folks with substance use disorder, then that must be that they are one and the same. And while there are some similarities between these two models, there's a lot of key differences, and that's what we're going to dive into. So the recovery housing model is, there's one, HUD certainly has its own definition for recovery housing, but recovery housing can also be referred to as, sober housing or sober living. But HUD has some very particular definitions and guidance out that refers to recovery housing, especially and in particular for any of these projects or programs that receive funding through a homelessness continuum of care fall under this HUD guidance. But plenty of recovery housing or sober living, a large majority of them are not funded through a COC. They're private pay or private funded. And so they don't necessarily have their own. We're going to dive into what some of the national standards look like. And there is an effort now nationally, as this influx of sober homes and sober living arrangements have come up across the country. States and organizations have started to recognize the need to regulate or establish standards of quality. And so that is starting to happen now across the country over the last couple of years. But up to the last couple of years, there wasn't really a firm definition. But the HUD definition is that it's substance use specific services, often peer support. Sometimes there are physical design features or elements that go into the project or the building that support individuals that are on a path to recovery from addiction. And they typically are, emphasizing abstinence as that approach. And HUD stresses, the key to this is that it's choice, and that individuals are there by choice, unless they're court mandated, which there is a caveat for that if you've been mandated through either a drug court or some other purpose. But if no one should never be coerced or feel that they have to go into recovery housing due to lack of options. And recovery housing is different from residential treatment, which is funded by health insurance, typically. It has 24-hour supervision. It often has medical services or a medical component built into it, maybe a resident nurse. They have a highly structured environment that often includes intensive, services, group services, one-on-one, and is typically time limited around 90 days. And so recovery housing, sober living, those types of models are really a follow-up to when folks receive that more intensive care at that residential level, or maybe there as a follow-up to that type of level of treatment, typically. So unlike supportive housing, which, as I mentioned, operates from Housing First, harm reduction framework, recovery housing, sober housing operates from a different framework. Its primary goal is to support a sober, abstinence-based lifestyle. Your housing is often dependent upon certain expectations for behavior and participation of services. Relapsing will most certainly cause you to lose your housing, although HUD is very clear that no one should ever be returned to homelessness because of relapse, but an effort should be made to connect people to other forms of housing. But unless you are accessing recovery housing through a HUD-funded project, more often than not, if you relapse, you are on your own for finding other forms of housing, unless they have that assistance sort of baked into the services. Outcomes are widely varied. There's emerging research on certain models that which we showed in the previous slide right here. Oxford House is one of those sort of promising models, and we're going to dive in a little bit deeper, but this is one of those models that's being lifted up as an emerging best practice for a peer-run recovery housing model. But this is newer. So outcomes are widely varied, especially if they're not affiliated with um, any of the sort of the certification processes or the standards that are set out by certain states. And often, uh, and unfortunately, what is also a common practice is that if individuals are accessing or using medication assisted treatment, which is the gold standard for, especially for folks with opioid use disorder, if they're receiving methadone treatment or buprenorphine treatment, these housing models, the recovery sober housing model is often incompatible or unsupportive because the perspective from individuals typically operating these recovery housing models is that, and this is an ongoing conversation within the recovery-based community, is whether medication-assisted treatment can be fully recognized for the gold standard that it is. So that's an ongoing conversation around medication assisted treatment, but often if you are on it, you cannot live in these types of, because it's not recognized as fully abstinent, which is unfortunate because it is a medication, and we have an enormous amount of evidence that shows its success in helping people achieve their goals around their substance use, their opioid use in particular. So side by side, this graph really just shows the biggest differences between these two models. They both have their pros and cons. In permanent supportive housing, individuals have a standard lease, just like regular market rate housing. Tenants typically have no lease within recovery housing. Permanent supportive housing services are always voluntary services. That is a number one of the major mainstays of our standards of quality for supportive housing, is that your housing is not dependent upon your participation. Service providers are always expected to continue to try to engage tenants in services, but housing is never dependent upon participation. And that's where having a harm reduction based outlook comes in, because that's really rooted in a relationship that's built on honesty and trust and safety. And I often find that when you approach a real engagement with a client or a tenant from a harm reduction based perspective, you have more success in that engagement and connecting them to other services, in my experience. Participation is typically required in meetings or other services for recovery housing. PSH is harm reduction, recovery housing abstinence-based. Permanent supportive housing is permanent. Individuals can stay there for as long as they choose and for the duration of their lease. Recovery housing is typically time limited or transitional, not always, but typically. Permanent supportive housing is either subsidized or deeply affordable. Recovery housing is typically self-pay or no subsidy unless it's funded through a COC. And I'd love to know if folks are familiar with their local continuums of care. Do you work with them in your areas? Maybe you're a participating member of that continuum of care? Maybe you've never heard of a continuum of care. Let us know in the chat. So when we're talking about quality recovery housing, and we talked about outcomes, widely varying. And there's a National Alliance for Recovery Residences, NAR, and they have a certification process that they themselves as a national organization don't do the actual certification. They have 28 affiliates around the country that do this certification process and quality review process for them, but under a common standards that we're going to look at in a little bit. And so when you're looking into resources around your areas about, okay, if someone is looking for this particular type of resource, this is an excellent place to start. It's naronline.org. You can go on there and navigate to your state, see who the certification affiliate is in your state. I believe there are 2 states that have their own, they don't use NAR, they have their own sort of internal standard, but the point is that they do have standards. And this is so important to really identify quality partners, because there are a number, or there can be at least a number of these types of operators who are not, they're not using evidence-based approaches, that they're not, they're sort of profit driven, and quality in terms of success and being able to thrive for tenants can be severely affected and can be very actually harmful for individuals that are highly vulnerable and looking for support. And so if you're making referrals, you really want to make sure to this type of model for folks, you want to make sure it's not predatory, and that you're using organizations or partnering with organizations that are certified as much as possible. Here in particular, where I live in Massachusetts, that was before the standards came on board, and we have the Massachusetts Alliance of Sober Homes. And prior to MASH getting up and running and having support from the legislature and other key stakeholders, it was like the wild, wild west almost. They were popping up everywhere, and there was a lot of predatory behavior going on until sort of the community started standing up and saying, we need to take a harder look at this. And so it's very important to make sure who is operating those quality programs in your area. We had a comment from Kevin. Thanks, Kevin. Patient brokering is a major issue within recovery communities. Kevin, that's a really interesting comment. If you feel comfortable to come off of mute, I'd love you to maybe say a little more and explain to folks maybe what you mean by patient brokering, or what that means to you, if you feel comfortable. If not, I'm happy to just read out comments from the chat. But it is an ongoing issue, and sort of shuffling patients from one program to another, or funneling them using a profit-driven.
Yeah, thank you for that invite, Jamie. Yeah, it came to my mind because I just remember reading a Yahoo article a couple of days ago. I believe it was Lindsay Lohan's dad had gotten some trouble for patient brokering, and just no expert in patient brokering, but just from my, infancy type knowledge, just, it's big in our community for recovery-oriented communities, because it has a big implication to your point of driving for profit while not promoting some of those best practices, such as harm reduction, such as the social model of recovery within the practices that we're doing, so that people can have that long-term recovery and have a better chance with long-term recovery within our community. And kind of goes against the grain of the work that we're doing and trying to establish within, substance use services, and promoting those best practices, emerging trends.
Thank you, Kevin. I mean, it's such an important point. When we have a profit-driven healthcare system, much like the way we do, and you can see this happen often, and people become profit motivated, and it's not in the best interest of patients and people who are highly vulnerable and really need support. And so partnering with those quality providers and knowing who those providers are and which ones to avoid, quite frankly, is really important when working and connecting this population to the services in your area. Thank you so much for that, Kevin. So NAR outlines 4 levels that they certify on for support. And the Substance Abuse and Mental Health Services Administration, SAMHSA, has recognized them as their credentialing as a merging best practice. And so you can, when I send these slides out, you'll be able to follow some of these resource links. So let's dive into what each of these levels mean. And if you're interested, the more detailed standards of what quality means under these levels for NAR are available on their website. We certainly don't have time to walk through every one of them today, but if you're interested in what those details are, we have the links on here for you. So level 1 is the example of what that picture I had shown you earlier of the Oxford Home model. These are peer-based support and peer run. They're responsible for self-monitoring. They stay accountable to each other. Everyone typically pitches in. They do chores and house upkeep. But it's that co-leading peer support model and that's that Oxford House model. Level 2 have either some sort of leadership position within the house, a house manager or some sort of senior resident that's there to oversee any kind of operations or structure or rules. Another big difference between permanent supportive housing and recovery housing is, a recovery housing might have a curfew for a particular house. Everyone has to be in by 10 or whatever. Permanent supportive housing doesn't have anything like that. You have your own unit and your own lease, and as long as you're not violating your lease, you are good to go. But for obvious reasons, the recovery housing model has certain types of structure to keep everyone safe and that sort of approach. So that's a level 2. Level 3, meaning that they might have maybe licensed clinical social workers, other certified staff, maybe certified recovery coaches, or other clinical services that are above just a house manager or a senior resident, and then certainly above the first level, which is the lowest amount of structure and sort of social accountability, peer accountability. And then finally, the highest level has licensed treatment providers, mental health providers, maybe nurses, licensed clinical social workers, or psychiatry, maybe vocational counselors. And then this was mentioned, maybe depending on the size of the program, they might have a maintenance team or other legal staff. And this is the sort of the highest structured level. And so the next level beyond this would be that residential treatment, that licensed residential treatment model that we spoke about earlier. That typically lasts about 90 days and is funded through insurance. So I want to stop here and see if there are questions, other questions or comments. There's a big difference between recovery housing and supportive housing, even though they both can serve the interests of people that have substance use disorder and have specific housing needs. I think the key challenges around recovery housing or supportive housing, they both have their pros and their cons depending on the goals of a particular tenant, right? So for permanent supportive housing, abstinence is not a requirement to maintain your housing. However, a comment that I often hear from the permanent supportive housing providers that I work with is that if you have someone, you're taking a harm reduction approach, it's not abstinence based, and someone or several tenants in a single site situation are still using, and then you have other tenants that are trying to maintain their choice of abstinence and sobriety. And having to balance the needs of these two populations can often be at odds with each other when you're taking a harm reduction approach. And both our goals are worthy, both are in need of services and support. And so how do we balance that? And so for tenants who are choosing to engage in recovery and trying to maintain a recovery-based lifestyle, give them the option of having engaging in sort of an Oxford House model or recovery housing model might be the better choice for them to support their goals. Whereas someone who is not yet ready, and maybe they won't ever be, to engage in a abstinence-based road of recovery, then permanent supportive housing would be probably a better option for them, as they'll be more successful in their housing as they continue to work on other goals. And so really understanding what their goals are and what the options are in your community is really the most important thing here. And certainly HUD stresses the importance of choice. And it's often easy to say that, particularly when we're all operating under scarcity, but no one should ever feel as though they need to go into recovery housing due to lack of options, because it ultimately won't be successful if folks feel that that is because it's their only choice. And so choice is so critical. And Marcella just put a comment, a couple questions in the chat that we'd love to hear from you all. Are any of your health centers referring to either supportive housing or recovery housing in your communities, and how is that going? So we'd love to hear from you. Are you making these referrals for folks that are coming from the health center, healthcare world? And if you're not, tell us why. Maybe you're not, maybe you don't know how to access those resources. Maybe you don't know who to talk to. So we want to know either way. If you are, or if you're not, feel free to come off of mute, or use the hand raise function, or drop your comment in the chat. We'd love to know what the landscape is in your local area, so that we can maybe tailor some of our material or our content, lessons learned, to your local area as best we can. I know in one of the states I also presently work in the state of Maine, I work with a federally qualified health center that also operates permanent supportive housing and an emergency shelter. So they do all of the above. And so I'd love to know if any of you all are familiar with similar operations, or are making referrals, or if you're not. And in other states that we work in, there's varying levels of integration, right? So that one particular health center in Maine that I just referenced is pretty unique. They're the only one that is actually operating that way. But then in other states, for instance, in the state of Connecticut, they have intake coordinators. Their discharge planners can do direct assessments right there at the hospital before they're discharged, and make sure that they enter in through their COC coordinated entry process, so that they can get prioritized for housing before they even leave the hospital. And that's another very successful approach in making sure that people are getting connected to the services that they need. Great. Okay. So some of the next steps around this particular issue is how to actually access these resources. And so permanent supportive housing can often be the solution for people experiencing homelessness, but as I mentioned, choice is super, super important. And HUD also stresses this as well. And if you are accessing permanent supportive housing, and based on where you live or the type of project that you might be living in, especially if it's a single site and you have other individuals that have similar challenges but are not supportive of a recovery-based approach or abstinence-based, that might not be the best approach choice for you, and maybe a recovery housing environment would be better supported for your goals. And then of course vice versa. So permanent supportive housing is not always the solution, but it can be the solution in many cases. And recovery housing certainly plays a role on a menu of options to meet goals, especially if they're meeting those standards of quality outlined by NAR, and are operating in a sort of patient-centered framework rather than a profit-driven motive. In 2015, and we provide a link for this, as I mentioned before, HUD published its guidance for those recovery housing programs that are funded through a COC. And so for those of you, some of you are probably familiar, but just for those who are not, HUD provides funding for the homelessness response system, for permanent supportive housing, and other forms of housing through a continuum of care. A continuum of care in a state could be a whole state, like the state of Maine has one continuum of care, but most states have multiple, depending on where you are. It could be a city, it could be a collection of areas, it could be a county. It depends on where you live. So I encourage you to find out, if you're not already connected to your local COC, find out who your COC is and the membership, and their process for accessing what they call coordinated entry system, which is the prioritization list to get access to housing resources. And recognizing that having a menu of options for all the reasons that I've just discussed is really important. HUD published this guidance in 2015 for recovery housing programs that are funded through a COC under permanent supportive housing. And so it's permanent supportive housing with a sort of recovery housing model tacked onto it. And there's specific expectations, for permanent supportive housing funded through a COC. HUD has specific guidelines around taking a housing first approach, harm reduction, and these are not necessarily they don't necessarily run up against the grain, and they really outline how these concepts can work together. And so I encourage you to check that out if you would like a little bit deeper of a dive. And then finally, program quality matters, especially if someone's being referred through the COC, because the guidelines from HUD specifically state that entry should not be predicated upon a set amount of clean time. But again, I don't particularly like the use of the word clean. I would say period of abstinence or sobriety, or any income requirements or background checks or other barriers. HUD's pretty clear that they need to be as low barrier as possible, but it's up to us, individuals who are making referrals, to ensure that these standards of quality are being met independently. And certainly this guidance is put out, but it's not foolproof, and it's important to really inform yourself in advance that they really are meeting these standards before referrals are made, and that's going to be for the benefit of the people that we are setting out to serve. And so I also wanted to just put in a little bit of plug, and I'm hoping, Marcella, maybe you could jump in here to add to this if you feel inclined. That presently there are 32 states that have approved waivers around substance use disorder treatment, and 3 are pending. And what this means is that the states have a way to bill and recoup expenses for paying for residential substance use treatment, which often has a lot of limitations around insurance and to pay for it, and are likely going to grow these programs. And so, Marcella, I don't know if you wanted to add anything about this.
Just that these are, 30-day, 60-day programs, et cetera. The programs will be looking for, we should think about quality the same way Jamie's been talking throughout this. So you want to find not just the quality recovery housing, the quality of supportive housing in your community. You want to find the quality residential substance abuse treatment referral places for people. These are commonly, if you're a managed care state, these commonly go through the managed care entities that are covering behavioral health services in your communities. If you're a fee-for-service state like Maine or Connecticut, then you work with the program themselves, and they can usually get approvals that way. But I think it's very important to also try to build relationships with these growing programs in your community. Both, you're going to see people who have substance use needs, and they may want to be going to need the assistance of these programs, and people are going to need the primary care and other long-term outpatient behavioral health services when you come out. So this is one of the ways that the federal government and states are trying to address the opioid crisis, substance use crisis, the addiction crisis we've had for so long, and trying to shift that from criminal justice interventions, which didn't work, were incredibly traumatizing, were vastly racist, to a more treatment-focused system. But they are growing, they are new. So reach out, and if they don't call you back the first time, reach out again, because if you're seeing people who need this assistance, you want to be building those relationships and those referral networks.
Thank you so much, Marcella. Does anybody have any questions about this? About these waivers that we might be able to answer? This is an excellent thing that they're expanding this resource, and being able to have a way to pay for more residential substance use treatment is certainly going to meet an enormous amount of need that I know that we're all, the fact that you're on this webinar, tells us that you're seeing this in your community as well. So this is really excellent to see. Great. Okay. So what are the next steps, to meet this need in your community? As I mentioned before, you really want to familiarize yourself with your local COC, especially if you're working with folks that are low income or extremely low income. a lot of you can probably easily locate a number of quality recovery homes or sober homes in your area, but they're likely all private pay. And so, and are not typically covered, through insurance or any such thing. And so, if a subsidy is needed because someone is extremely low income, or maybe they are experiencing homelessness, then you're absolutely going to want to connect with your local continuum of care. And then ideally, your local continuum of care will have access to a number of different types of housing resources. That might be permanent supportive housing. It might be a recovery model, permanent supportive housing. It might be some transitional housing. Every COC is a little different in sort of what the menu of options that they have available, but also they're through their coordinated entry system and what their prioritization looks like. Every state has a slightly different formula as to who goes in front of whom in the line. And it's typically by vulnerability and how they score that and the housing assessment. And then folks are matched when housing resources become available. But in order to access those subsidized housing resources for people experiencing homelessness, you have to get onto the list. And that means to access the COC and find out, where those access points are. In some communities, you call 211 and they can do it straight through 211 and they connect you to the appropriate person to do the assessment. In other places, you can physically go to a location, or there's only certain providers that do the intakes. So it's really important in your local area to know who does that and how you can facilitate those referrals. And even if you don't have anyone to actively refer right now, but you do work with folks experiencing substance use disorder, or you want to make those referrals, reaching out now and finding out all the information you can about the process and establishing those relationships is really going to serve you well going forward. Use the Finder tool through NAR. Find out who your NAR affiliate is in your state. If you're in one of the 28 states where NAR has someone, there's 2 other states. I want to say it's Arkansas and one other state that has their own state-driven quality standards. So I encourage you. And if you live in a state where they don't have quality standards, and then it'll be very important to maybe do your own research through your own networks to find out what are those quality providers, what are their outcomes, what are their policies and procedures, and finding out that information for yourself so that when you're making these referrals for folks that that they're being referred to a place of quality that's not going to perpetuate harm. Identify your local harm reduction program. This is really, really critical. If you haven't already done that, I encourage you to do that, whether that's an outreach program or a physical syringe exchange, whoever your local harm reduction provider is. If you're working with people with substance use disorder, having a good relationship with that program is going to serve you very well. I've often found that when trying to establish a new relationship with someone who has substance use disorder, active substance use disorder, particularly if someone's not interested in pursuing recovery right now or abstinence right now, that being able to make a referral to them, they likely already know who their harm reduction provider is, but if they don't, that really can demonstrate to them that you're serious in taking a harm reduction approach, that you can get that relationship off on the right foot, that shows that you care about, that you have no agenda other than their safety and their well-being, and that can go a really long way in establishing a good rapport and relationship necessary to help them achieve whatever goals that they've set out. And then finally, establish a good working relationship with any agencies that you might want to make referrals to. Find out what their policies and procedures are. Inform yourself in advance. Having all this information is going to smooth the way for that referral. We'll be able to prep any person that you might be working with and set what some of the expectations are, and it will just all around make the process smoother for whom you're working with. So that covers our content for today on our sort of high level look on what is supportive housing, what is recovery housing, how do you access these resources. I would love if folks have other questions. I'd like to open it up. Anything relating to accessing housing resources or working with people with substance use disorder in your communities. I'd love to take a moment to answer any follow-up questions. And then I'd like you to ask yourself as we conclude, sort of what's one thing that you will do in response to what you've learned today? Is it reaching out? Is it doing to some providers? Is it doing a landscape scan? Is it finding out where the location of quality recovery residences and sober living arrangements are in your community? And what's the cost? What are the resources that are available that are subsidized through the COC for people that are experiencing homelessness in your community? What is one thing that you're going to take away to go in your own community and find out where these resources are? Otherwise, I'm happy to answer any questions that folks might have on this topic before we adjourn. I know we had scheduled an hour and a half for this, but we typically like to leave some time at the end for conversation and questions. Otherwise, if there are none, then we'll all get some time back to our day. So I'll just give it a minute for anyone who might have a question. Okay, well then, if there are no other follow-up questions, I would just ask everyone to please fill out this evaluation poll that's popping up on your screen. Thank you, Kathy. Just take a moment. We'd love to hear from you. Your feedback helps us to tailor these sessions in the future. So thank you so much. And we will be sending these slides out. My contact information is also included. I'm happy to follow up with anyone by email if you have other questions that might come up. And I just want to say thank you all so much for being with us.